Okay, so good afternoon. Now we've got the technical issues resolved. It's my great pleasure to introduce Dr. Vidya Navaratnam to give today's Margaret Turner Warwick seminar. Vidya is currently a Jeff Laurent Fellow at UCL and Imperial, visiting us from the University of Western Australia in Perth, where she's an ILD consultant at the Sir Charles Gardner Hospital, if I remember the name correctly. So I first met Vidya shortly after she graduated her medical degree at the University of Nottingham, and she was a fellow with Richard Hubbard undertaking her PhD in epidemiology, where she published one of the seminal epidemiological papers in pulmonary fibrosis, and we're still citing that at the moment, the rising incidence of IPF. And it's from that work that Vidya set up the Trent lung fibrosis cohort, a case control cohort of patients with IPF, looking at clotting factors, and that was another excellent piece of work. And that cohort, that case control cohort, is still available, and I think you're trying to move it to Australia. It'd be good to see.
It's gone. It's in Perth now.
Fantastic. That's great news. So there's still lots of work to come from that. Yeah, and Vidya's career has gone from strength to strength, as you can tell. And so I'm going to stop now and let Vidya do the rest of the talking. So thanks very much for coming, and it's been a real pleasure to have you.
Thank you so much, Gisli, for the invitation to talk today. And thank you to Natasha for sorting out all the logistics involved for getting me here today. So my name is Dr. Vidya Navaratnam. I'm a respiratory consultant with an interest in interstitial lung disease, and I'm also an epidemiologist. And what I'm going to talk to you today is about palliative care in interstitial lung disease, and especially where we are in our landscape of palliative care, what the evidence behind our current guidelines, our practice, and certainly addressing the gaps in the literature, and present a little bit of pilot data from my time here in London. So this is just a quick outline of what I'm hoping to talk to you about today. So why is palliative care important in pulmonary fibrosis? A brief snapshot of current guidelines and what they suggest around palliative care. And then a quick whirlwind of the available literature. So we'll start with qualitative studies, perceptions of patients, their caregivers, and also healthcare professionals about the role of palliative care. And then look at what evidence is out there for access and delivery of palliative care to patients with pulmonary fibrosis. Now, most of this work is done around IPF, which is the most common type of pulmonary fibrosis. There's also some emerging evidence about the importance of early integrated palliative care, and I'll talk through that. As doctors, we prescribe lots of drugs, some of which have a good evidence base, some less so, and how we manage symptoms, especially around symptom burden. I'll talk through the evidence behind that. And like I said, finally, we'll present some data that own work I've been doing here at Imperial, looking at place of death in people with pulmonary fibrosis. So most of you here will live, breathe pulmonary fibrosis like I do, but just in case there's anyone in the audience or online who doesn't know what pulmonary fibrosis is, it's an umbrella term for fibrotic lung disease. And there are about 200 different types of variations of interstitial lung disease, some of which have a known cause, like rheumatoid arthritis. The most common type of pulmonary fibrosis is actually idiopathic pulmonary fibrosis, which essentially means lung fibrosis of unknown cause. There's lots of evidence, not just from the UK, but worldwide, that disease burden is going up. So there's increasing incidence and prevalence. So now in the UK, we expect to diagnose between 8,000 and 9,000 new cases a year. And these patients have a very high symptom burden. So when they present with breathlessness, with cough. And the picture there is changes to their nails, which is called clubbing. And the diagnosis is made through CT scanning, which gives you quite a distinct pattern. The prognosis for pulmonary fibrosis is still very poor. It is a life-limiting condition, and it has a prognosis worse than some cancers. And hence, the role of palliative care has always been thought to be an important part in pulmonary fibrosis, because the treatments that we have, and not all patients will have access to these treatments, involve slowing down rate of decline in lung function. So you still get worse, you still get more symptoms, it's just that you don't get as worse as quickly. So if this was a cancer, you'd be calling this palliative chemotherapy, palliative radiotherapy. The drugs come with quite high side effects. So not only do you have your symptom burden, breathlessness, cough, nausea, weight loss, you also get the side effects from the drug. And a lot of the time when you're in clinic, you're trying to justify giving these drugs to patients. Am I actually improving their quality of life by slowing down how quickly they get worse, or actually am I adding to their disease burden? So what is palliative care? The WHO defines this as an approach that improves the quality of life for patients and families faced with life-threatening illnesses. And that's what pulmonary fibrosis is. It's a life-limiting condition. And despite the treatments, there's no good evidence that median survival is actually prolonged. And actually some interesting data that was in the ERS conference from an abstract from Anne Morgan looks at people who were diagnosed just 4 years before antifibrotics, the introduction of antifibrotics to the NHS, and 4 years after, and there's no real difference. And although some meta-analysis of clinical trials populations seem to think there is a little bit of improvement in survival, there's still a lack of real-world data about whether these treatments actually improve survival in pulmonary fibrosis. Now, in 2008, the Labour government at the time introduced an end-of-life care strategy, which focused on higher quality of end-of-life care for non-malignant conditions. And this is because prior to that, access to palliative care had been quite limited to people with only cancerous conditions. And there's a lot of misconceptions, which unfortunately still remain today, that palliative care equals end-of-life care. And that, and what I hope to convince you is that it doesn't necessarily have to be the case. So as I mentioned, that pulmonary fibrosis has a poor prognosis. We always knew this about IPF, which is the most common type of pulmonary fibrosis, but certainly in the last decade, we now tend to broaden our kind of understanding about people with non-IPF pulmonary fibrosis. And essentially, once you start to fibrose, your prognosis is the same. So median survival of between 3 and 5 years. And the graph on the right-hand side is a little bit old, but it puts into context the 5-year survival compared to common cancers. And as you can see, IPF has a worse prognosis than bladder, breast, colon, kidney cancer. The only cancers that have a worse prognosis is pancreatic cancer and lung cancer. So what do the guidelines suggest about palliative care? So this is easy. Everyone agrees that it's important. Everyone thinks that patients with pulmonary fibrosis should get access to it. So even as far back as 2013, with the first NICE guidelines for management of people with idiopathic pulmonary fibrosis, they suggest introducing palliative care. In the quality statement, which was published in 2015, it says that people with IPF and their families and carers should have access to services for palliative care needs, irrespective of disease severity, so from any point in their diagnosis. And time again, you've got the European Respiratory Society clinical practice guidelines that came out a couple of years ago, which talks about the importance of palliative care for COPD and interstitial lung disease, but then goes on to talk about how there's limited evidence space for palliative care in both groups of people. Even in 2011, the ATS guidelines for idiopathic pulmonary fibrosis talks about introducing palliative care, introducing it early and making sure patients have access to it. And then the last diagram in the right-hand corner is from the position paper from the Australian and New Zealand Thoracic Society that was published last year. And this covers both IPF and progressive pulmonary fibrosis. And it talks about being vigilant for that fibrotic progression, but at the same time thinking about pulmonary rehab, palliative care involvement along the same lines as lung transplant. So that's kind of how important it is, and how much weight it plays in management of patients. So I quite like this diagram, which kind of, I think, focused, certainly in my mind, the palliative care approach and how it expands in pulmonary fibrosis, where you've got patients who are at their end of life, and there is a very specific and direct type of who have very specific and direct care needs tailored towards end of life. But then if you go back further towards earlier in the disease trajectory, actually there's lots and lots of different ways that you can do early palliative care interventions, and that is becoming more important and more evident, and starting almost at the point of diagnosis with that needs assessment. What does the patient need, and how can I help and try and improve their quality of life? So the qualitative work goes back for quite a long time. This is one of the earlier papers that was done at the Brompton and at King's by Sabrina Bajwa, who's a palliative care physician with an interest in ILD. And what she did, she conducted interviews with both patients and with healthcare professionals. And this focused on end-of-life planning and what information was required by patients and healthcare professionals. And even 10 years ago, and this is before antifibrotics were on the market, patients had a good understanding that their condition was terminal, but didn't necessarily relate that to prognosis. So there's clearly something in the communication of what we tell patients, that they get it. This is a life-limiting condition, but when you ask them about prognosis, everyone's not sure. None of the patients had palliative care discussions from their healthcare professionals. None of them had end-of-life discussions either. And then when you talk to healthcare professionals, they will admit that it's very difficult balancing the information. How much information should you give to the patient versus the need to give them hope? And then when you go back to the patients and carers, there is very clear from that group that they want more information, that they want anything that you can give them. So fast forward to 2019, this is a patient and expert survey that was done by the European Lung Foundation, so it's Europe-wide, huge a number of participants, 286 patients and caregivers and 69 healthcare professionals. And the conclusion that it comes to is that patients are unaware of the importance of palliative care. So they still, 2019, years after 2008, when we started talking about, improving end-of-life care, trying to get to non-cancerous conditions, improving access to palliative care, people still think of palliative care as being end-of-life care. And what they don't see it as is symptom burden management and improvement in quality of life. And healthcare professionals said all their timings of palliative care discussions were done in the context of end-of-life care. And that is how it was framed, I guess, not just by the patients, but also by healthcare professionals. So it's quite a big mind shift to change, where essentially both groups need to start thinking about what can be done to try and improve quality of life and the role palliative care has to play. And then this was followed up a couple of years afterwards with the Irish Lung Fibrosis Association, and they had a World Cafe. So they advertised it through their website, invited patients, caregivers, and healthcare professionals. They conducted semi-structured interviews, and they had 6 predefined topics. And this was around practical planning after diagnosis of pulmonary fibrosis. It talked about palliative care and symptom management, end-of-life considerations, psychological support needs, and then what happens with acute exacerbations, etc. And that's the drawing that's come up, that actually the patients and the participants have come up with, that a lot of it is to do with jargon and to do with stigma around of terminology, and the perception, again, that actually if you rephrased it and focused it more on leading a better quality of life, there would be more inclination to access and to engage palliative care, both from patients and caregivers and from the healthcare professionals. And this is more recently from Natasha Smallwood's group in Melbourne, where she did a qualitative study on, again, perceptions of palliative care that was done over the past couple of years. 15 patients and 2 carers, and 3 themes come out. One of all is that patients are overwhelmed with the symptom burden and not knowing how to manage that. There was also a lot of perceptions regarding taking opioids for the management of breathlessness. And then there were also misconceptions around referral and access to palliative care. So since 2013, we really haven't come very far in how patients perceive this and actually how healthcare professionals perceive this, despite guideline after guideline after guideline, going that early palliative care is important, access to palliative care is important. There just seems to be this big gap between what we know we should do and what we're actually doing in clinical practice. And this was done from the UK, from Andrew Wilson's group, where they looked at healthcare professional surveys, and this looked about barriers and delivery of palliative care. So all healthcare professionals, 15 of which were interstitial lung disease specialist nurses, and they asked them about referrals or reasons for referring to palliative care. Unfortunately, most of them still talk about end-of-life care, but as the second most common indication for referral was actually symptom control, and then the third most common was actually psychological support. So it gives you a bit of hope that the message is starting to drip in. Healthcare professionals felt confident that they could discuss palliative care with their patients in their role of palliative care and managing their symptoms. But what seems to then break down is the delivery of care, where the roles get crossed and people are not really sure who's meant to do what. And the general consensus is that it should be a multidisciplinary team, which is the very core of actually delivering ILD care and integrating palliative care into the current existing MDT. So next, I'm just going to talk about how patients access palliative care and the kind of evidence behind this. So again, going back to just over 10 years, another lovely piece of work by Sabrina Bajwa, who did a retrospective study looking at 2 ILD centres here at the Brompton and then at King's College. And she looked at what was termed at the time progressive idiopathic fibrotic lung disease, which consisted of patients with IPF and also some with NSIP or non-specific interstitial pneumonia. There are 45 patients, most of whom reported breathlessness in the last year of life, but only half of them were prescribed medications, so opiates, to try and help with the symptoms of breathlessness, and less than 20% were prescribed benzodiazepines, another medication to help with breathlessness. 62% did not have any palliative care input in the last year of life. And for a terminal disease, only 13% had been asked where they would like to die and had documented in their medical records their preferred place of death. And this, again, is now more recent data. So this is work from Anne Morgan, who's part of Jenny Quint's group. And this is more representative. It uses electronic healthcare records, looking at palliative care referrals in people with IPF. And you can see that palliative care referrals, or the rate of palliative care referrals, are going up. But you're more likely to get referred to palliative care if you have another respiratory comorbidity. So if you have a concurrent diagnosis of COPD or a concurrent diagnosis of lung cancer, you're more likely to be referred to palliative care. For the whole cohort, only 20% of people with IPF were referred to palliative care. And this data that goes up to February 2022. Out of this, 80% of people were over the age of 70. They had just under 8,000 deaths during the study period. And within the people who died, only 34% had a palliative care referral. And that is a forest plot of various factors that influenced, that may or may not have influenced a palliative care referral. And then this looks at people who died. So within the cohort, people who had been referred to palliative care and who had died. So we're now getting down to smaller numbers, so 2,658 people, and looking at the timing of referral. And as you can see, most people only get referred fairly late, so within the last year of life. And actually a third get referred within a month of their death, and very few people actually get referred if beyond 12 months of their death. So we're still very much only referring fairly late within the last 12 months of life. And when you get to the end of your life, if you have IPF, do you get the same quality of end-of-life care than if you did lung cancer? So this is a study that used data from a Swedish registry that captures everyone who's been prescribed long-term oxygen. It's called SWEDOX. And you can identify patients with fibrotic interstitial lung disease from there. And they linked that to the Swedish palliative care registry, which captures information in the last 7 days of life. So that's a combination of medical record, electronic medical records, but they also send out participation surveys to the primary physician and the nurse responsible for the patient in the last 7 days of life. And this is irrespective of whether you've had any contact with palliative care, and a data collection is mandatory. And what they tend to do is they try and get the survey done within 7 days of death. So you don't have as much recall bias as if you sent it out 6 or 12 months after. And some interesting findings this graph on the left-hand side shows you the median survival from initiation of long-term oxygen therapy to death. So the median survival is 8.4 months. In the last 7 days of life, people with interstitial lung disease were less likely to have a palliative care consultation compared to people with lung cancer. They were less likely to have an end-of-life discussion compared to if they had lung cancer, and they were less likely to die in their preferred place of death, and also less likely to die in what they called a palliative care setting, which was on a palliative care ward in a hospital or in a hospice. So the graph on the top right-hand corner, that looks at prevalence of symptoms. So that's perceived symptoms from the physician and the nurse looking after them in the last 7 days of life. And what they found is that people with ILD have reported breathlessness at higher rates compared to lung cancer. Everything else seems fairly equitable: pain, anxiety, nausea, and confusion, but people with ILD are more breathless. And the graph at the bottom is symptom management. And again, symptom management and whether the symptoms are relieved or unrelieved with management. And you've got ILD and you've got lung cancer. And with breathlessness in ILD, you've got a greater proportion of people whose symptoms of breathlessness are not controlled despite intervention and medications to try and control that. And so this study comes from Japan, again, looking at a fairly similar questions. If you have ILD, do you get good end-of-life care? Much, much smaller study because it was from 4 hospitals in Japan, and they had a total of 83 patients who died of ILD and 89 patients who died of lung cancer. And this time it was questionnaires that were sent out to the patient's family after death. And their primary outcome was looking at quality of death and dying scores, which they derived from the questionnaires. So a slightly longer median duration between death and completion of survey, so 19 months. But again, you can see this is, again, top hand graph is prevalence of symptoms as perceived by the family at the end of life, comparing ILD to lung cancer. And similar to the previous study, it reports that breathlessness is more prevalent, or the perception of breathlessness is more prevalent to families anyway in people with ILD compared to lung cancer. They found that actually end-of-life discussions were much better. So over 90% in people of ILD had an end-of-life discussion and 95% in lung cancer. The timing of end-of-life discussion was much later in people with ILD. And again, the use of palliative care services as an inpatient was very low. And then the graph on the right-hand side is the domain of scores of quality of death and dying according to ILD versus lung cancer. And in general, the quality of death and dying overall is lower in people with ILD than it is in lung cancer. So what about early palliative care, and is this important? So again, just taking a leaf out of the lung cancer community. This is again published in 2010, and it looked at early palliative care interventions in metastatic non-small cell cancer. And the primary endpoint was just looking at quality of life and looking at changes in mood. So they had 151 patients, all newly diagnosed with metastatic non-small cell lung cancer, randomized to receive standard oncological therapy or standard oncological therapy along with early access to palliative care that was within the clinic. And unsurprisingly, people with early palliative care interventions had better quality of life scores, reported lower rates of depression and anxiety. But what was interesting was that they also found that the median survival was higher in people with the early palliative care group. So early palliative care group had a median survival of 11.6 months, and those in standard care had a median survival of 8.9 months. So suggesting that even if you have this terminal condition and you receive standard care, which will be palliative or chemotherapy or radiotherapy, having something extra, having your symptoms well controlled, not just improves your quality of life, but also may actually prolong your survival. So have we thought about this in IPF? Have we done this in IPF? And there are two small retrospective studies that have actually looked at this question. And the study design is a bit sketchy. It's not the most robust evidence, but it certainly is food for thought, and the only evidence that is out there. So 2018, this study was done in Denmark, and what they did was they looked at early palliative care over a period of time. So this big ILD center, and they introduced early integrated palliative care in 2016. And what they did was they collected data from patients who were treated with standard care, which is before the introduction of this early palliative care approach, and then compared it to patients who were treated after. And the main outcome for this was looking at healthcare utilization. So number of respiratory-related emergency room presentations and hospitalizations. And then secondary outcomes was looking at place of death, so actual versus preferred place of death. And as you can see, the small numbers, so 22 people got the integrated multidisciplinary care, 10 was for standard care in the period before it was implemented. But across the board, there was a reduction in emergency room attendance, in number of hospitalizations, and more patients with MDT early palliative care died in their preferred place of death. And this is likely a reflection again of advanced care planning and just having the time to talk to patients about what they want and give you that time to plan the logistics around it. And then similarly, this is another retrospective study that was done between 2018 and 2023. So again, they split their time periods where they had a pre-introduction of early palliative care service, so pre-2021, and post-introduction of palliative care service, which is after the 1st of January 2021. And so therefore, after 2021, the MDT care consisted of a palliative care physician, a respiratory physician, some nurses, and a psychologist. And patients could ask to have the MDT approach, or they could have standard care, which was seeing the normal ILD physician. And their primary outcome was actually looking at location of death. And then their secondary outcomes, again, was looking at emergency department attendance, and they also looked at median survival. So not surprisingly, locations of death has changed, whereas before, most people tend to die on the respiratory ward, and after introduction of the MDT early palliative care approach, patients tended to die more at home than they did in the hospital. And again, the number of emergency department presentations reduced when they had the MDT, early MDT approach. And this is a kind of a reflection of that their symptoms are better controlled and they're less likely to seek out medical attention. Both before and after had similar characteristics, and median survival from diagnosis to death was 86 months in the group that had standard care, so pre-2021, and it was 115.9 months in post-2021, which is when you had the early MDT care approach. So definitely not robust evidence as a prospective randomized clinical trial, but certainly raises questions where else you never would have thought that this approach that worked in lung cancer would work in pulmonary fibrosis. But there is some, patchy evidence at least raising the possibility that it might be an approach, and it might be an approach that we should start thinking about taking. So next, we'll talk about how we manage symptoms. So symptoms of breathlessness and cough are the most predominant ones that cause a high burden. And we manage these with morphine and with benzodiazepines. And what's the evidence for what we do? A lot of this comes from COPD, but there are two clinical trials actually published fairly recently looking at the impact of morphine and chronic breathlessness in ILD. And this primary outcome is the visual analog score for breathlessness with morphine or compared to placebo. And surprisingly, it doesn't work. So there's no change in VAS score between morphine and placebo, and just more reported symptoms of constipation and nausea, which are common side effects of morphine. The other clinical trial that was done, again, published in 2023, and this again looked at morphine versus placebo and looked at breathlessness intensity, and they scored it twice. So you scored it once in the morning at that point in time and once in the evening at that point in time. And this was a study that was done in Australia, and it was a crossover trial. So patients who started off on the morphine group had it for 1 week, then they had a 1 week washout period, and they went into the placebo group, or vice versa. And once again, you find that in terms of scores of breathlessness, there's no clinical, or there's no difference in how breathless people are when they're on morphine or when they're on placebo, with just more side effects. So 14.3% of people with morphine reported nausea, 17% reported confusion as an adverse effect. Which then led to the European Respiratory Society doing a huge systematic review looking at opioids more generally in breathlessness in chronic respiratory disease. They found 17 studies in total across all different types of chronic respiratory disease, most of which come in from COPD. Only one is a purely ILD population because the 2023 trial hadn't reported at the time that they were doing the systematic review. And across the board, what they found was that if you conducted a lab-based or exercise-based clinical trial where you gave someone morphine, you got them to exercise in a lab, and then you asked them about perceptions of breathlessness or scores of breathlessness, that favors the use of morphine. And that's the graph on the left-hand side. On the right-hand side is the graph where it's home-based. So patients are asked about breathlessness on a day-to-day activities at home, with and without morphine. And you find that actually across the board for all chronic lung diseases, that morphine doesn't make a meaningful impact on breathlessness. And this looks at the subgroup analysis where they looked at more advanced lung disease, again with only a slight favor towards morphine being of any benefit. All the trials reported quite serious adverse events, so nausea, confusion, drowsiness, constipation in the morphine group. There was one particular trial who actually reported increased hospitalization in the morphine group and actually excess deaths in the morphine group, which then led to this being published last year, the ERS Clinical Practice Guidelines for Symptom Management in Adults with Serious Respiratory Illness. And they have said that the evidence for morphine is actually limited, and they suggest not using opioids for the treatment of breathlessness alone in people with advanced lung disease. And that's across the board. We talked a lot about safety of the drugs and how some of the trials indicated actually maybe they're not effective, but they're not safe. This is work from the Swedish registry again, so SweDox, the long-term oxygen therapy registry, and they started off with patients with fibrotic interstitial lung disease prescribed long-term oxygen, and they linked that to prescription registry data and the national inpatient registry data. So it's a fairly big cohort, 1,600 patients. 12% were prescribed benzodiazepines and 15% of them were prescribed opioids. And the forest plot on the left-hand side is for hospitalization, and for both benzodiazepines and opioids, it looks like there's an increased risk of hospitalization. And for the forest plot for all-cause mortality, it looks like actually if you prescribe someone any dose of opioid, there is a theoretical risk of increased mortality. Now, you can argue that these are patients with end-stage lung disease. They've got a terminal condition. Does it really matter? You know, if controlling their symptoms, or you can't really tease out the association as well, that they probably could have died from their lung disease and it's all-cause mortality. But I think what's really interesting is the hospitalization, because if you're trying to control symptoms and keep people at home, but actually the medications that you give them end up in hospital, then you're not really doing them much of a service. What other drugs do we have? So there's been a trial for mirtazapine for treatment of breathlessness in people with COPD and ILD. So 225 participants and were given either placebo or mirtazapine. They started off at a 15 milligram dose and titrated up to 45 milligrams. And the primary outcome was asking patients how breathless they were or their worst breathlessness in the preceding 24 hours. And again, this was a crossover study and found that actually there was no significant difference between the mirtazapine group and the placebo group in terms of levels of reported breathlessness. And once again, mirtazapine had more adverse side effects. It also didn't really contribute to a reduction of healthcare utilization in terms of hospital stays or ED attendances. What we do know, however, is that morphine is good for cough. So this was published last year, led by Phil Molyneux, Pacify Cough. It was a phase 2 study, placebo-controlled two-way crossover trial from 3 ILD centres from the UK, so the Brompton, Manchester and Liverpool. And patients were given 5 milligrams of controlled release morphine twice a day versus placebo. So they had 14 days followed by 7-day washout. And the primary endpoint was change in daytime or awake cough. And compared to placebo, morphine definitely reduces your cough frequency during the daytime and when you're awake. In terms of adverse events, so nausea and constipation, again, more common in your morphine group. But what's more reassuring is that serious adverse events weren't an issue in the morphine group. So that worry about all-cause mortality, there was 1 death, and that was in the placebo group. But bearing in mind, it is a fairly small study, and again, it's a phase 2 trial, and certainly a phase 3 trial to see whether this is just as effective as needed. So this brings me to the work that I've been doing over the past couple of months, which is looking at place of death in pulmonary fibrosis. And the reason for doing that, again, is to try and build your evidence base from the bottom up. All the studies on place of death have tended to be small. They've been single centers and for short periods of time, so and have been descriptive. I've never really been able to paint a representative picture of a big pulmonary fibrosis population. So using data from CPRD, which is primary care electronic healthcare records, that was then linked to HES APC, which has admissions for inpatient activity across England, and also linked to ONS death, which is gives you death registration information on date of death, cause of death, and also place of death. We then went on to look at the number of people who die from, or the places of death that people, place of death in people with pulmonary fibrosis, how that's changed over time, and risk factors for dying in hospital. So we identified our pulmonary fibrosis cohort within CPRD between 2008 and 2019. So intentionally stopped at the 31st of December 2019 because of the COVID pandemic and all the biases and implications that it would put on place of death and access to healthcare resources. And truly wanted to paint a picture of what's happening in pulmonary fibrosis. So just over 37,000 people, and then this whittled down to just people who had died. So for all-cause mortality, we had just over 20,000 deaths in that 11-year study period. And then using the linked data, we were able to identify the people who died from their pulmonary fibrosis, where that was identified as the underlying cause of death. And that got us down to just over 13,000 deaths. And so this looks at the percentage of people who die at different places and over time. So hospital deaths are still the highest, but it does look like hospital deaths are coming down, going from a prevalence of just under 70% to now about 53% in 2019. And you would expect this because 2008 was the introduction of the guidelines of end-of-life care for non-malignant diseases. So a big push focusing on end-of-life care if you didn't have cancer, asking about advanced care planning, and asking again about a place of death to try and encourage people to die in the community. What's interesting is that hospice deaths haven't really increased over time. That's probably related due to funding and the number of fixed hospice beds we have in England. And then we looked at factors associated with dying in hospital. And if you're male, you're 10% more likely to die in hospital after you've adjusted for other covariates as well. If you're younger, you're more likely to die in hospital. And what was interesting is that there definitely is cultural sensitivities towards place of death. So if you are South Asian, you are twice as more likely to die in hospital than you are in the community. And this looks at comorbidities and whether certain comorbidities mean that you're more likely to die in hospital. And it all seems to come back to cardiovascular disease. So if you have a diagnosis of ischemic heart disease, or if you have a diagnosis of heart failure, you are more likely to die in hospital. I would have thought lung cancer would also be the case, but we didn't actually have that many people with both lung cancer and pulmonary fibrosis in our cohort, only 198, which is why the confidence interval stretches 1. But there's a suggestion there again that if the study period had been for longer and the numbers had been bigger, that people with lung cancer as well would be more likely to die in hospital. And that despite what we know, that if you have lung cancer and pulmonary fibrosis, you're more likely to get palliative care input and referral to palliative care. Sorry, it's not come out very well, but these other factors associated with dying in hospital, the first box plot up here is just the referral to palliative care. So that is only within GP records, and it's a record for if you've been referred to palliative care. And that really reduces your odds of dying in hospital. So the odds ratio for that was 0.22. So if you're 80% less likely to die in hospital if you've had a palliative care referral at any time point before death. If you were hospitalized for pulmonary fibrosis as the main cause for your hospital admission, then you were 4 times more likely to die in hospital. And the last two looks at so this one is hospitalization within 30 days of death, and you're more likely to die in hospital. And I think that's a reflection of probably having an acute exacerbation of IPF and needing the extra supports in hospital. If you were hospitalized more than 30 days after your hospital, more than 30 days before death, then you were more likely to die in the community. And probably, again, reflective of the fact that you've had some palliative care input whilst you were in hospital. And the last one here looks at deaths that occurred within diagnosis of 12 months. So if you were diagnosed late, so if you died within 12 months of diagnosis, you're more likely to die in hospital compared to if you were diagnosed within 12 months. So just to summarize, everyone agrees that palliative care is important is an important tool, is part of the delivery of overall care to people with pulmonary fibrosis. What hasn't changed is the low referral rates to palliative care and the fact that the timing is still done close to the end of life. There are still misconceptions about palliative care being end-of-life care, not just in patients and their carers, but also within healthcare professionals. And there's emerging evidence that early palliative care integrated into standard care for people with pulmonary fibrosis improves your quality of life, reduces attendance to emergency departments and hospitalizations, and it also encourages advanced care planning. So they get their preferred place of death, and they're more likely to die in their preferred place of death. Thank you again for having me. A huge thank you to the University of Western Australia and the Institute for Respiratory Health for the Laurent Fellowship for Respiratory Health and the being able to spend the past few months back in London. A huge thank you to Rachel Chambers and Joe Porter from UCL and at Imperial, to Gisli, and to the amazing and wonderful Jenny Quint and her research group who've really looked after me for the past 3 months. Thank you.
fascinating. It's great to see palliative supportive care at centre stage, and it's often the sort of Cinderella subject in ILD. So it's actually fantastic to get such a clear presentation on that. Some really interesting findings you have there. So two things that I'll start with. Also wait for other questions. Actually, I'll let you go first.
Thank you. So, I mean, one of the difficulties I think with all the research that you've shown us is exactly the setting that you put this in the, we know what palliative care should be, but no matter whether you're a patient or a healthcare professional or even a researcher who looks at the studies that you were pushing at, what we actually use as palliative care is basically end of life. That's what we keep describing it as.
Yeah.
And so there's an awful lot of the research that you were describing where they were almost using those two terms interchangeably. So there was this palliative registry based on this 7 days before death, and it's like, well, that's end of life registry, things like that. So there's one of the difficulties, I suppose, is there a real defined term, palliative care, that you can use to classify people appropriately for research in order to better understand what is palliative care and when is it working best? And on that sort of idea, with your CPRD data, were you able to look at the dates of palliative care referral and sort of time difference between referral and death, and understanding whether it's just a palliative referral that mattered, or whether it was the time from, the timing of that palliative care referral that actually had an impact on where you died?
So I'll answer the CPRD question first. So I haven't looked at it yet, but I've still got a week left. Quite a lot to catch. So yes, it is. As I literally managed to get the results for this on Monday, and one of the I've made a list of things to go back and see if I've got time to do, and one of it is looking at that timing of referral, and whether that is a bigger impact or any referral, because at the moment it's just any referral makes an impact, but looking to see whether we can tease that out a little bit more would definitely be interesting. With your first question, I think that still hasn't, it's almost like palliative care needs a rebrand, and we need to separate out symptom management and end-of-life care. That hasn't happened across the board. It's very country specific. Certainly where I work now, I've got a great palliative care colleague who set up what he calls the symptom clinic. So when I refer patients, I'm going to see, like, you're going to see my colleague who runs the symptom clinic, and he's going to help you with your symptoms. And that seems to anecdotally go down better with patients, because because it's so entrenched, the stigma is so entrenched that palliative care equals end of life care. I think it is up to the palliative care community, alongside respiratory and other kind of specialties, to help them rebrand and separate out the symptom burden with end of life care. In the hospital that I work in, they've done it fairly well with chronic kidney disease patients. So they've got a joint clinic where they will take patients with end-stage chronic kidney disease who are either not suitable for dialysis or have opted out of dialysis. So it is that transition from symptom management all the way to end of life. And I think it's that kind of approach that I see with pulmonary fibrosis as well, from the point of diagnosis, to say you're going to go to the symptom clinic, but as you get worse, the symptom clinic will also help you with your advanced care planning, et cetera, link you in with other support services. If you want to die at home, we will try and do our best to do that.
So I got the microphone working now. So in the comorbidities associated with dying in hospital were ischemic heart disease, heart failure, trend towards stroke, but it crossed across the sort of line of unity, all of which are associated with sort of a common vascular pathway which wasn't included, i.e. hypertension. And obviously, Georgie's published quite a bit in the link between hypertension and IPF. Is that data available? Do you think you'd see the same thing? And should we be focusing a bit like palliative care, improving outcomes, not just, I mean, you talk about symptom clinics, but actually palliative care may improve long-term survival, as you showed with the excellent lung cancer data. If we focused on treating comorbidities, might we improve long-term outcomes more than perhaps focusing on antifibrotics?
No, I completely agree. I think having been here and having listened to Brini Selvarajah talk about her ILA work, and it seemed like cardiovascular comorbidities was a huge burden in her ILA cohort, and they have increased all-cause mortality, and what isn't clear is what they die from. I suspect on a hunch that might be more likely to be from their cardiovascular complications than their respiratory disease, because by definition they're not an ILD, they're pre-ILD, so they haven't got that respiratory failure. So there is a reason why they're dying, and they're dying more than the general population, even in people who are smokers, and that might be the connection that unifies everything. That actually, there is a role for antifibrotics, and there is probably a role for whatever asset that comes up for control or reversal of fibrosis. But your earlier intervention to that is actually aggressive treatment of cardiovascular disease. And so if someone comes to you with an ILA, you say, check your high blood pressure, check your cholesterol, check your diabetes, because that's what's going to save you first.
I guess also what I'm driving at is that there may be a specific mechanism which ties in hypertension to IPF.
Yeah.
And we've got a suite of antihypertensives. And at the moment, it's, well, let's start with A and work our way through to Z. Whereas actually, there may be a specific antihypertensive which is preferable for patients with IPF than patients without. I mean, potentially.
No, absolutely. And I say this as someone who has held a pipette for like 3 months of my entire life, that the endothelium and the signal of endothelium dysfunction seems to be the big driver.
Take note, James.
And I will be the first one for the question of the time. Thanks very much for your talk. I love it a lot. Just a quick question is about, did you notice there was any difference in the geographic distribution of the referral with the timing of, the working?
So in terms of place of death, we did have data for region. I just didn't have enough time to put it in a lovely color-coded map, but there are definitely regions where you are more likely to die in the community compared to hospital. And that is from memory, southeast, southwest, northwest, and Yorkshire and Humber. London isn't, you're more likely to die in hospital in London. Again, I can only suspect that is due to access to palliative care and palliative care networks, and access to hospice beds as well.
So, new question, do you think it's more for simply distance from the sort of tertiary center of these, and things also kind of socioeconomic, cultural, the private area, different things like that?
Yeah. So in terms of deprivation, you're more likely to die in hospital the most socially deprived you are. So that's certainly the trend that the data has shown, and that's adjusting for everything else. The regions are quite broad because I spent a little bit of time trying to see if I could map out place of death from distance to your prescribing center, for example. And there isn't a practical way of doing that. If they're collecting data within the BTS registry on place of death and prescribing center, then they might be able to look at that, or distance from hospital if you're rural versus urban, but not within CPRD data, no.
So I've got one final question before you can sort of go back for cheese and wine, but it struck me that pain was quite a pronounced symptom in end of life in IPF, almost as much as it was in cancer, and the effect of treatment was about the same for cancer and IPF, which surprised me a lot, actually. Certainly it's not something I'm familiar with clinically, a lot of pain. So, I mean, what's your experience? I mean, the data are pretty clear, but I mean, do you think that's a generalizable feature, or was it specific to that cohort?
I, like you, was really surprised about the pain. It's not something that I instinctively think of in the clinic. I don't think it's, unless they've got, terrible rheumatoid arthritis and deformed joints, it's not something I've come across in clinical practice. So it might be specific to the cohort.
Okay, thank you once again. A fascinating talk, and I look forward to seeing all these data in published form. So thank you.